not without a good excuse. Now, the next thing that I want to talk about is the fact that medical students, oh, all right, good. Now I can see myself. I feel a lot more comfortable. I don't know what you did differently. Okay, so the next thing I want to talk about is that the students really do have a responsibility. So if you're not going to be on the ward rounds, just like if you're going to be late, to really let somebody know that you're not going to be there. I understand that it's difficult and it's challenging because sometimes you come to ward rounds and you may actually feel ignored. Sometimes you come to ward rounds and you think that you can get more out of staying home and reading your book, which frankly, in some cases may be true. But it's developing this sense of professionalism that if you are supposed to be somewhere, that you are going to be there when you say you are going to be there or when you are assigned to be there. So things as simple as, if you're not going to be there, just letting somebody know. But it really should be a very, very good, I always tell my med students that you in med students sometimes seem to have a very high rate of illness, because there's no reason why we should have a lot of absences. So you really do have to just try to take the clinical wards seriously and to act as if this is your job, which it is really. And if you're not going to be there, you do have to let somebody know why you're not there. And unexplained absences are not okay, and prolonged absences are not okay, because this is your profession. And pretend as if you were being paid to do it. The other thing I'd like to echo that Dr. Akar said already is that you really, particularly in the era of COVID, but in general, you're really going to need to take a lot of initiative for your own medical education. And two students can be on the same firm and have two totally different experiences. And what the difference really is how you approach the rotation. You have students that clerk, they go to the nurses, they ask the nurses which patients need to be seen, and they ask the interns, they stay in touch with the intern and the residents throughout the evening, and they get to see all the patients and they know what's going on. And they know when the patient is going to the operating theater. And you have other students who wait to be told what is happening. And if you wait to be told, everybody is so busy, particularly in this time when there are more patients and less staff available, that everybody is so busy that people will forget to tell you that a new patient was admitted. But there are other ways for you to find out rather than just relying on your resident to call and tell you. It's really just a matter of being around. So I'd like to echo that. Now, the next thing I'd like to speak about is just some things that are unique to surgery. And surgery is a particularly challenging discipline because I think it can be quite physically demanding. And, it's different from, giving a patient a medication and maybe an hour or two later, you stop back and you see if the medication worked. It's pretty much like you have to be there. And so it can be extremely physically demanding. And I remember, I remember being in medical school, and I'll just give you I didn't, as Melissa said, who introduced me, I went to medical school overseas. So it was a little bit different. And different good and different bad. But I'll just explain to you how it was different in order to kind of drive home my point of how demanding it can be, but also what is expected of you and how it helps you to be a better doctor. So if I'm to think about a typical day, ward rounds always started at 6 o'clock. And that was rain or shine, sleet or snow, literally, because I trained in where it was winter, like at least 1/3 of the year. So rain or shine, sleet or snow, everybody was expected to be there for ward rounds at 6 a.m. But before the ward rounds, the medical students and interns would have to have pre-rounded, written all the notes on the patients. And so when the chief resident came at 6 o'clock in the morning, basically all the work was done. The patients were seen, the notes were written, and the chief resident was just fine-tuning the plan. So therefore, if you were going to have to round with your chief resident at 6 o'clock and you had 3, 4, 5 patients assigned to you, even as a medical student, you had to make sure that you were ready to present them at 6 a.m. And so I remember many a morning in the winter, digging out my car from 4 in the morning to make sure that I could get to the hospital so I could see my patients and do my pre-rounds before the chief resident would arrive at 6. Okay. And it was kind of like there were no excuses accepted. And we had other Jamaicans in the program. We had Jamaican chief senior residents, Jamaican attendings, where we call them attendings in the US. In Jamaica, we call them this equivalent person a consultant. And these persons basically, persons just rise to the occasion. If you have to dig your car out of the snow, you dig your car out of the snow, you know? I can remember waking up in the morning and just praying that when I got out there, like I wouldn't have to dig too much, or I would see one of the snow blowers passing and I could wave down one of the men to come and help me to dig out the car if there had been too much snow overnight. So, so that was it. And then you went to rounds by 6 o'clock, everything was done. And at 7 o'clock, the reason rounds were at 6 was, depending on the hospital you were, was that at 7 o'clock or 7:30, it was what we called knife to skin. So that was the time that your surgical incision was supposed to start. So apart from seeing your patients between 6 and 7, you would have to make sure you got to the operating room, got changed, and reached there before your consultant, because it was knife to skin at 7 or 7:30 a.m. And they took it really seriously. And the reason they took it so seriously was because in the US, you pay for every minute of time in the operating room. So if you don't, and you're literally building many institutions by the minute. So if you don't get knife to skin at 7 or 7:30, somebody's got to pay that bill. So, so it was tough. I would say it was tough because in between your surgical cases, and it is the same way here, in terms of the fact that you're doing your operations, but while you're in surgery, you're probably going to get called to go to the emergency room to see a referral. You may have to go upstairs to the medicine ward to see a referral. And you really have to be able to juggle your time between what the patient and your attention, not just your time, but your attention between the patient who's on the operating room table and a patient who may need to be seen in accident and emergency or on the medicine ward. And there becomes a big deal in terms of time management and prioritizing what you have to do. But that's what you're here to learn now. Nobody expects you to get it right from day one. Nobody expects you to know from day one. But, you know, sometimes, especially with me having done this for a while, you hear the story when you're in the operating room, you know the case is going to take another 2 hours. And you're like, you know what? It can wait till I'm finished. And sometimes you hear the story in the operating room when you're in the middle of a surgery and you're like, you know what? I need to send a senior resident to see this patient. This sounds serious. So you're juggling being in the operating room and having to see patients outside of the operating room and taking care of your patients on the ward. So it's a little bit tough. but enjoyable, very fulfilling. And one of the things I always say about surgery is that the highs are really high. You know, when somebody comes in with a ruptured appendix and they're really sick and they're really in pain, and you take it out and they get better and they're home in 24 hours, it's really, really very fulfilling, because you've done a kind of huge public service. But the lows are also very low, because sometimes the outcomes are not that great, particularly in cancer and trauma. So the next thing I'd like to pivot to is just saying a few things about COVID and surgery, because I think even though I didn't hear all of Dr. Carr's presentation, she certainly kind of brought you in touch with some of the realities which we face with COVID now. COVID and other infectious diseases, not just COVID, they're here to stay. And we learn to live with them. And then as a clinician and as a trainee in particular, you're actually probably maybe even at a little bit more of an advantage than those of us who have been practicing for 15, 20 years, because you're coming into the environment where COVID is front row and center, and the way you practice living with COVID is front row and center in terms of the precautions you must take. So whereas persons like myself and Dr. Akar have been doing this for a long time, and we're almost developing somewhat of a paradigm shift to how we take care of patients who have these highly infectious diseases, you guys are kind of learning it from the beginning. So what do? Well, we made some adjustments in surgery, and it may put you guys at a bit of a disadvantage because you can't see as many patients as we used to see. Because in trying to protect the medical students, what we have done is asked you really only to be involved with patients who we think, and I put the word think in there, are COVID negative. So if they're coming from the emergency room, we don't know if they're COVID negative. Usually within the first 24 to 48 hours of their admission, we will then know if they are COVID positive or negative. If they're negative, they will go to a particular ward, and that is the ward, or wards, I should say, and those are the wards which the medical students have access to. So what it has done, therefore, is it has cut down the number of patients you can actually see, because if they're in the emergency room or they're on the rule out COVID ward, you would not be able to see them at this time. Now that could change in the next few months because it's a dynamic process. But that may cut down the number of patients you can see. And that's why you need to really take advantage of all the opportunities, not being late, being on time, not having these excuses for why you can't come in, because you're going to be interacting with less patients than students would have been a year ago, certainly in surgery. So once the patients are known to be COVID negative, then yes, we have medical students on those wards and we have medical students interact. But here's the caveat. The caveat is that the patients may have tested negative when they come in, but then for one reason or another, we may decide to retest them, and then they come back positive even though they were originally negative. So that should bring you in, and we've had several patients who have fallen in those categories. So that should really bring you in tune to the fact that we are, that you still need to be hyper vigilant, even if the patient is supposedly COVID negative, okay? Because patients can become positive even in the hospital. So in terms of taking these patients to surgery, one of the things that we learned as surgeons from the Italian literature, and if you remember in the beginning, in the early days of COVID, in April, May, Italy was really having a very hard time. And one of the things that we learned as surgeons was that the risk of transmission was actually particularly high in the operating room, and particularly high with certain kinds of cases. We know, for example, that laparoscopic cases actually had quite a high risk of transmission of COVID, probably because of the insufflation of the carbon dioxide and eventual evacuation from the abdominal cavity. And also, there were some early thoughts that use of the cautery device, the diathermy device in the operating room, also because of the aerosolization, increase your risk of surgeons' risk of getting COVID. So what happened is that a high number of surgeons who had been in operations in the early days ended up becoming positive. And it's just the reality. You know, we all chose to be doctors, and we have this as well as other infectious diseases upon our hands. Clearly, it's not the only one. Clearly, surgeons would be at a higher risk of getting things like hepatitis or HIV from needle sticks, for example, because you're basically working with needles half the day if you're in the operating room. So it's not the only infectious disease that's a problem, but it's just the current infectious disease that we're getting used to. So in order to protect the students, we try to make sure that all of the cases that you go to the patients are COVID negative and have had a negative COVID test within 24 to 48 hours before surgery. But there are patients who will slip through the cracks, so you still have to be hyper vigilant. In terms of what it means for us as surgeons practicing today, obviously you're not going to know if all patients are positive or negative, because there are going to be emergencies. There's going to be a gunshot wound, there's going to be a stab wound, there's going to be your acute limb ischemia, or whatever it is, where you have no time to be able to wait on a COVID test. And in those patients where the status is unknown, or the patients are COVID positive, they need surgery, right? So you have to make the necessary adjustments. So what we have done at UWI is that we have a dedicated theater, operating room theater, which will deal with the COVID cases, which has been specially prepared to be safe to do so. In the few cases I've had where we have to operate on these patients, it's again very physically demanding because you have on all this gear. We obviously wouldn't allow medical students at this stage into those cases if we know the patients are positive or if the status is unknown. So, you know, so you probably would not have that experience. However, what I would say is you have on all this gear, you have your N95 mask, and you're decked out in several layers. And on the best of days, the operating rooms are hot and a little bit uncomfortable. So it's a challenging physical situation, but we do what we have to do. So, so where you fit into all of this is pretty much some of the things that have been discussed already. Taking your universal precautions, you have to have a high index of suspicion that even patients who are negative are positive. You have to remember the unique situations with surgical patients in that the operating room is a potentially very high risk environment. And because of the aerosolization, and our anesthetic colleagues in particular who we work very closely with, certainly have an increased risk when these patients are either unknown or positive, because they're intubating these patients. They're right interacting with the patient's airway. So I think I will stop there. Surgery is fun, but I think I would be lying to you if I didn't tell you about some of the challenges in terms of being a surgeon and choosing to be a surgeon. But it's also, as I said, the highs are very high. So I'll stop there and I will take any questions that anybody may have.
All right. Well, love it. We have a question. Nakisa, feel free to turn on your mic if you can.
Hello. I understand that career is important in everything, but I also grew up being very close to my family, and I do want to be like my mother, where she took care of me even though she worked. So, how does being a surgeon affect family life, even taking care of your parents and all?
Um, hmm. That's a good question, and I'm always asked it, particularly by females in medicine. I don't know that I yet have a good answer. I see Jermaine Levine had the same question. I don't know that I yet have a good answer to it. I think that something gives. I think something gives. And there are times when um, you have to make difficult decisions. And I'm sure Dr. Akar has been in the same situation as well, where you have to make difficult decisions. And first of all, I don't know how Dr. Akar does it, because she's always there and she's always smiling and she's always pleasant. And if once I'm stressed and I have somewhere else that I could be, I am not pleasant. So she's like a superstar. But anyway, so anyway, anyway, um, so the so it's particularly it's demanding, and you have to make difficult choices. You have to make difficult choices. I don't think it's an either or. I think that if you plan your life, you can I wouldn't say do everything, but you can be pretty balanced if you plan your life. Um, you know, for and if you're efficient with your time, I've learned over the years how to be a lot more efficient. Um, I spend just as much time as I need to. Um, I try to get to the point and highlight this patient has problem 1, 2, 3, within the first few minutes, and this is what we're going to do to fix problem 1, 2, 3. And I do that so that I can drill down with the residents what needs to be done. And honestly, so that I can also protect myself, because I can't be there all the time. So I think that over time, you gain the experience of how to be a lot more efficient with your time. It wasn't always like that. Certainly when I was a student and in the early segments of my training, I spent a lot more hours, just because you're a newbie and you're quote unquote at the bottom of the totem pole, for want of a better word. And so you spend more time in the hospital. But then as you do get experience, you also learn how to do things more efficiently, such that you don't necessarily always need to be there. So it is challenging, I won't lie about it. And there's times when, for example, my son before COVID anyway, is a very good swimmer. And so I make it my point of duty never to miss a swim meet. And I have actually been successful. I have not missed a swim meet. And how have I done that? By sometimes asking colleagues to cover for me. And honestly, sometimes I have to reschedule things. Sometimes I have to reschedule patients. And there, but it's a personal decision that I have made that I'm not going to miss a swim meet. So, I mean, I suppose as the years go by, I will have to miss some, but so far, I think I've done a pretty good job of not. Um, so essentially what I'm saying is, that a long-winded way to answer your question is that sacrifice, that something gives, right? As I said, I've had to reschedule patients. I've had to ask persons to cover for me. There's even though I've never missed a swim meet. Swim meets are my big thing. Even though I've never missed a swim meet, there are other events that I have missed. So some things have given on that side as well. So I think something gives, something will have to give at some point. And you have to make a personal decision about what you choose to prioritize. So that's and you become more efficient. You definitely become more efficient. Do I think there is a point in your career that's optimal to start a family if the choice is made? I think, again, I think that's a personal decision. I don't know if Dr. Akar is still here or not.
I'm here, Hillary. Some personal questions.
Okay.
Very personal questions.
Yeah.
Very personal.
Yeah, I think that's a very personal decision as to when you want to do that, and people have to decide. I mean, if the stars are aligning for you at a particular point personally, but not professionally, then I usually make the personal decision. For example, I'll give you an example. When I was coming back to Jamaica to live, no, I don't mind the question.
Don't apologize, because we are women and it's real.
Yes.
Don't apologize.
No, don't apologize for the question. Not at all. I'm happy to answer the question. And I think Dr. Carr doesn't have a problem either.
Not
I think
at all.
what we're saying is that they're personal decisions, but not that the question is inappropriate. So I think, so for me, for example, when I was finishing my surgical training, I could have gone straight in general surgical training. I could have gone straight into my fellowship, or I could have come back to Jamaica, because it was always my goal that I was going to come back and practice in Jamaica. And at that point, I had to make a decision as to what did I want to do. And the reason, I can tell you the reason that I decided to come back home at that point in time was because my parents were getting older, and I just felt like I needed to be back in Jamaica. And I'm really glad that I did, because, shortly after I came back to Jamaica, my mom started getting sick. So I think you have to make the decision. And I subsequently went back and did a fellowship in vascular surgery after a few years. So I think you really have to make the decision based on your personal circumstances and and I think that your family, it's my opinion, that the family decisions and the decisions you make from that perspective are probably more important. But that's just me. Everybody may not feel the same way. So I usually make the decisions as to what's best for my family, and then try to align my professional goals with what's best for me as an individual and for my family. And each person has to make that decision for themselves.
Can I say something, Hillary?
Sure, go ahead.
I like the questions because they are very, very real. There are two important things: your parents, looking after them, because they sacrifice a lot to put you through this program. And you need to be able to look after them and give them the care they need. The other part, and like you said, you came back because you saw them getting older, and you are able to intervene in their management. The other aspect of it now, when it comes on to starting your own family, is hard. And I can only say to you that when you're choosing that partner must understand the kind of life that you are going to have. As much as you may love somebody, he needs to understand the kind of existence you are going to have, the kind of what he's getting into, because you need support. You can have that child, you can have that fulfilling life, but in order to do it, it is a blessing from God, and you need to find a partner who is understanding, caring, and supportive, and your parents will always cover your back. Don't worry about that. That's why you have to look after them.
Absolutely. I agree with that. Okay, I see a question in the group. It says, Doc, I've seen you on a certain politician's Instagram. I just want to know what advice you'd give to us read politics as students and doctors. What if a patient accuses you of treating them differently because they wear a color you don't support since you're public. By you, I mean any doctor. Okay, here's the way I answer the question. All right. I think that your clinical work has to speak for itself. I think everybody, or certainly most persons, I don't hide my political affiliations. As you said, you saw me on a politician's Instagram page. I don't hide my political affiliations. And what I would say is that it has in no way at all, not even minuscule, affected my professional life.
Agree.
I have several patients, and the patients come from both, they come from both political parties, prominent persons on both sides of the aisle. And everybody knows my political affiliations. So, and the reason I think is that it has not affected my professional life is because I think that persons will say that I am a good doctor. Amen. So because I take the time, I listen to the patients, I respect their time, I try not to show up late. If I'm late, I apologize. The first thing I do, I make a personal note. I'm walking into this room 5 minutes late. I am going to issue an apology. I do it every single time, right? So because I have taken the approach that that I respect and I interact with patients in a certain way, and I think I'm pretty okay at what I do, then regardless of the side of the aisle, persons come to me, and persons call me from both sides and ask me to sort out problems. So I don't think it has affected it in any way, but so the politics is secondary, and how I interact with and take care of the patients is primary.
Agreed.
Dr. Akar, you have any thoughts on that?
No, you're absolutely right, Hillary. And this is what I'm sorry about, because this is the same thing I'm saying, the interpersonal skills, the fact that you have made it clear, you apologize when you come into the room, all right? Those other finer qualities that you have honed and developed are what make you stand out, in addition to which you're good at what you do. So no matter whether you are of one party or the other, the person who is ill is seeking the best person they can find for the job. So respect you. Your work speaks and your professionalism speaks for you.
Yeah, absolutely. So, so I mean, I know that there are persons, and I mean, I think maybe to some extent victimization does occur, but I've heard persons say it before. But for me, it's, I love politics, I love medicine, and so both of them just have to work one way or the other, right? Okay. Do you think marrying someone in medicine is better than someone outside of medicine, as they may not understand our life? Whoa, I think I'll give this one to you, Althea.
Lord have mercy. Marrying somebody in medicine is rough. And if you are ambitious and that person is ambitious, then it's going to be even harder. To make a marriage work, one of you is going to have to take the back seat. One of you is going to have to allow the other one to soar, and the other person sits back while that person soars. What you hope is that the partner who soared will eventually recognize what you have done and give you your time at the right time. It is difficult. This is why I said when you go start family, you pray about it and you choose the person clearly. Don't watch no Grey's Anatomy, no bother what, because hello, there are movies, okay? It is hard. So make up your mind, if you're marrying another doctor, somebody has got to sit back and let the other one forge ahead until your time comes. Nobody watch Grey's Anatomy and all, it don't work. That's not real life.
Yeah, I agree. You know, and I just extend that to other professions too, because you know, you may be in a relationship with somebody who's an attorney or somebody who's a banker or whatever, and those professions can be very challenging too. I mean, I know people who work in banking that work longer hours than I do. So so I think the most important thing is, as Dr. Akar said, is to choose your partner wisely and have the discussions about how are you going to parallel / intersect your careers such that one person might move at time X and the other person move at time Y.
Exactly.
All right, we love it. Are there any more questions? We're closing off the session soon. If there are any other questions, feel free. I'm going to give 5 seconds. All right. Oh, Nakisa is saying, my parents did something like that. So I like that point that you made. All right. So just wrapping up.
One quick thing. Sorry, I didn't acknowledge Jason's comment. Jason says, one day I want to be Minister of Health and PM too. And nobody can stop me.
Oh,
Yes. All right. Well, Jason, talk to me off the air. I want to make sure you make the right decisions.
Let's go. Oh no. Love it, love it, love it. On that note, specifically right now, Dr. Hillary Brown, we really appreciate the time that you've given us. One of the major things that came out, especially to me, was when you highlighted that the clinician that you are right now is a clinician that you will be. And, you know, when you were highlighting the challenges that you faced when you were in school abroad, and we're looking on like, whoa, that's a lot. We need to remember that these very challenges that we're facing right now will be our stories in the future. So how we grasp them and move forward will determine how fulfilling that story is when we're moving into our purpose even more. We thank both of you so much for the time that you spent, especially for the fact that this session became more of a mentorship, especially as us as younger doctors to be are looking up to you. We appreciate you so much. Thank you for facing the challenges that you did so that you can make our lives even easier, especially as we traverse and navigate this interesting time. Tanya Henry is saying wonderful session, and I completely agree. So according to our schedule, we have vote of thanks and closing remarks coming up next. Mr. Chair, Devon Malcolm Brewster, I ask that you indulge me for a quick moment just to give a little teeny bit of motivation for our students, especially those who are in third year. Now, talking to one of my family friends, we were kind of half sculling church. So we were having a conversation outside, and he was sharing a story that was shared when he was in prep school, where his teacher was asking them, how far into a thicket can a dog go? Stay with me. How far into a thicket can a dog go? And when everyone was putting up their hands and, you know, giving their various answers of meters and feet, the teacher said no to each of them. And the answer was halfway. Now, third years, you guys right now around you seems dense and it seems unsure, but that just might mean that you're in the center of the thicket. And once you reach midway, you're on your way out. So as we head into our way out, let us become in this moment the physicians that we want to be in the future for the sake of our patients who we are to meet. With that said, I'm closing off as your moderator. It was my absolute joy to be with you. And Devon Malcolm Brewster, I am passing back over to you for the vote of thanks and closing remarks.
Thank you so much, Melissa. I think there is no amount of words I could say to, accurately express how much I think this session was really inspiring. I think the presenters, Dr. Althea Cart-Stewart and Dr. Hilary Brown, you both did justice to, I suppose, a very vague request because I did not, we were not very specific, extremely specific. We left it up to their competencies to determine what they think might be best for the students to hear. And I think that you delivered really well as expected. And so just want to say thank you to you, Dr. Althea Cart-Stewart. You know, I mean, the funny thing is that your presentation was pretty much exactly what you told my group when we did IMP. And so it helped me, it helped like one of my colleagues who was also under the tutelage. You know, she's watching as well. And, you know, we spoke before this, and, you know, she agreed with me that, you know, it was not in that moment, you know, it was one thing to hear this, you know, feisty woman, at least that's how it sounded first, come and tell us all of this. But then as we entered medicine and surgery and pediatrics and went into the clinics, we better understood what you were saying then. And I'm sure the students who heard you will agree to the same. And you know, interestingly, I'm only just realizing that I had both Dr. Cart-Stewart and Dr. Hilary Brown as my IMP during IMP. And it's just a coincidence. That wasn't the reason why I asked them both. But Dr. Hilary Brown, thank you very much again for your presentation. You know, the weather has been causing havoc everywhere, and Dr. Brown was not spared, but she made an effort to be here regardless. And you know, anybody who knows me, just like Jason, I too have political aspirations and all this good stuff. And so it was very much refreshing to hear from you your whole take on that question from Jason, as well as everything else that he said. So I just want to say thank you very, very much, Dr. Hilary Brown as well. And then to also say thank you to our wonderful host, Miss Melissa Flinch, who delivered just as we expected. You know, thank you so much for, you know, responding to the call to serve in this way this evening. And it was very much, I'm sure everyone can agree, a blessing to have you. And then, of course, this webinar, it was made for students, but if no one showed up, then probably we would all pack up and go home. So just need to say, thank you very much to all of you students for joining. There were students both from Mona as well as from Cave Hill. We hope that next time we will have students from all the campuses of the University of the West Indies, but we start somewhere. And so thank you very much for coming. And I trust that we will not allow the wealth of wisdom to fall on deaf ears, but that we will take this information and practice it. And for sure, I think it is very clear, and I'm sure Dr. Brown and Dr. Cart-Stewart can corroborate. I believe that they are very willing individuals to impart their knowledge, you know, although Dr. Brown may not be like Dr. Althea, who's always a ray of sunshine, but I'm sure she's willing as well. So, you know, when you see her, see them when you get back to the clinics and so forth, you can always reach out to them. And I'm sure that they will be as gracious as they were to me to respond positively to your requests for any clarity, anything of that sort. So with that said, on behalf of myself, as well as the team from Hyper Academics, especially Xavier Brown, Owen Hyatt, and Eric Dixon, who are also directors of Hyper Academics, I want to give thanks to you guys, and I pray that you will have a good evening in spite of the weather, and you will have a very good week. So thank you very much, and bye-bye.
Right.
Okay, bye. Thanks for having us.
And thanks for the opportunity as well. Bye.
No problem.
Great. Have a good week.
You too.